So I'd like to introduce our first speaker, Dr. Kristine Barnden, who is an obstetrician and gynaecologist at the Royal Hobart Hospital and also works at Women's Imaging. She's got an interest in high-risk obstetrics and obstetric and gynaecology ultrasound. And she also teaches ultrasound skills to obs and gynae registrars at the Royal Hobart Hospital. She's a coordinator of the high-risk antenatal clinic at the Royal Hobart Hospital, and she's got a couple of very good talks that are coming up. So without further ado, I introduce Dr. Kristine Barnden.
Hello, that's a really bright light there. Thank you so much for asking me to talk. First talk is about fetal growth restriction. Now, the first thing I'm going to say might be the most interesting thing I say all day for people of a certain mindset, and that is that fetal is spelt without an O. The etymology is Latin, and the O snuck in England around 1590, but the spelling without the O is recommended by the Oxford English Dictionary and the British Medical Journal. So there. And also we talk about restriction now rather than retardation, much as we talk about miscarriage rather than abortion. So the reason that this is just a very exciting thing to talk about is that there's lots of exciting developments, but it's also just really our core business. It's one of the ways that we can have most impact on obstetric outcomes. So detecting just the small baby, and I'll talk a bit more about how we can do better than that, halves the risk of stillbirth. It can optimise gestation at birth, because if we know that a baby is small, we can deliver them that little bit early, and they're less likely to require a caesarean section or to be born in poor condition at birth. We now know that growth-restricted babies have ongoing problems through life, from neurobehavioural disorders to an increased risk of metabolic problems and diabetes, hypertension, and now there's work on what sort of secondary interventions we can institute if we know that a baby's born small at birth. But obviously, and this is where you guys come in, detection is crucial. This slide just illustrates very nicely the impact on stillbirth rates. This is from a study done in the Midlands in the UK, where, here we go, the overall stillbirth rate was 4 in 1,000, but babies that weren't growth restricted had a 2 in 1,000 stillbirth, whereas growth restricted babies, the stillbirth rate is up to 16 in 1,000. If you look at the growth restricted babies, if they were known to be growth restricted babies, the stillbirth rate is half of that of those who weren't known to be growth restricted. So it is important. But we know, and we've always known, that not all small babies are growth restricted. They might just be normal small babies. And we also know that not all growth restricted babies are small. And if you look at that growth trajectory there, although if you just took a snapshot of the last, if that was the only scan you did, you'd be a lot more worried about the baby down the bottom. But in fact, if you've been watching the whole way along and looking at the growth trajectory, you're actually thinking, hey, that top baby's the growth restricted one and the bottom one's actually probably fine. So a lot of the research, which I'm going to be talking about, has been aimed at identifying those fetuses that are at risk of adverse outcome, not just the ones that are small. I'm going to backtrack for a bit to looking at the physiology of growth restriction and how that then translates into the tests that we do. So very, very basic. What a baby needs to grow normally is to have a mother with adequate concentrations of oxygen and nutrients that she can transfer to the fetus. You have to have a placenta which is capable of making that transfer, and a fetus which is able to utilise those nutrients and has genetic programming for normal growth. And in that slide you see all of the causes of fetal growth restriction. You can break it down so it's a lot more complicated into fetal disorders, maternal disorders and placental disorders. And the fourth and probably foremost box is there's actually nothing wrong. So those are the babies that are constitutionally small. We've got the dates wrong, always have to think about that, or the measurement has not been done well. So that's something that when you're reporting a scan and a baby looks small, you always have to think of those things. Fetal disorders, usually it's the early severe growth restriction, and that's where you're doing the anatomy scan. particularly in those that are early and severe, to see if you can see any sign of abnormalities, anything that might point to a chromosomal disorder, anything like that. But by far and away, the main cause of fetal growth restriction is just primary placental insufficiency, and that's what most of my talk will be focused on. But it's always worth keeping in mind that there may be other disorders behind the growth restriction, and for that reason it may behave a little bit differently than the usual model that I'll be talking about. So the placenta. How the placenta works, is, this arrow isn't working for me. Spiral arteries here take maternal blood into the placenta, where basically the maternal blood is just this huge bath. And in that bath are these little trees of fetal vessels called villi. There's a close-up there of the spiral artery taking the maternal blood to the placenta, and the villi with the fetal vessels branching out so that there's this massive area of exposure for nutrient transfer. And some villi here which are anchoring the fetal part to the maternal part, and that's how the placenta stays attached. So in your normal setup, you have early in pregnancy, the placenta invades into the spiral arteries and destroys their muscular coating so that they become large and maternal blood flows through very easily under low pressure. In a placenta where the pregnancy is destined to develop growth restriction or preeclampsia, that doesn't occur, and so what you get is not so much that there's less blood coming through, but it's coming through under really high pressure, and that actually destroys the villi, and it's a progressive. And I never actually understood why umbilical artery dopplers deteriorated until I saw this. And so there's this progressive destruction of villi, rupturing of the anchoring villi, formation of thrombi, and so your nutrient transfer is just not working. And so that then relates to the first of the dopplers that we do, which is the uterine artery dopplers, where here you have your normal flow. So the uterine artery is upstream from those spiral arteries, and if they're nice and wide, you get lovely flow and diastole. If they're very constricted, you have your decrease in flow and diastole, and often those notches as well. But the notching isn't as important as the overall measurement of pulsatility index, which the greater the difference between systole and diastole, the higher the pulsatility index. They're still struggling to find a place a bit, uterine artery dopplers. We do know that in the first trimester, if it's abnormal, it's very specific for later complications, but unfortunately it's not been very sensitive, so it hasn't really been routinely used for screening. In the second and third trimester, we know that an abnormal uterine artery Doppler is associated with an increased risk of adverse outcome. How often should you measure them? Those that are abnormal in the first trimester may become normal subsequently. Those that are normal in the first trimester then may become abnormal. And that's the picture that shows not just the uterine artery Doppler there that's normal, but also a normal placenta. And often if there's severe placental insufficiency, you see these little placentas that look like cupcakes. There's not much actual area where it meets the uterus, and they're thick and hyperinflated. That's actually extra blood in the placenta, and when they're delivered, they shrink right down. So umbilical artery Doppler, now you're looking at the blood flow through the cord to the placenta. So that's telling us about the fetal circulation. And where we have these nice healthy villus trees with lots of fetal blood coursing through, there's your normal placental waveform. But as those villi are destroyed, or if there's not many there in the first place, you get that resistance to flow in the umbilical cord towards the placenta. Not useful for screening low-risk pregnancies, but very, very useful for managing high-risk pregnancies where there is already growth restriction. And even by the time you get an elevated PI, that's associated with about 60% obliteration of the placental bed. So that's the placenta. What happens in the baby? In the preclinical phase, there's already some altered metabolism and endocrine changes in the baby, but the first change that we can see is that there's not the same laying down of glycogen in the liver as energy stores because there's just not enough energy to spare. And so we see the abdominal circumference decrease. That's because we measure it at the level of the liver, less storage in the liver, smaller abdominal circumference. We then enter the next phase where the baby's becoming hypoxic and you get your arterial distribution, so more blood to the brain, more blood to the heart and the adrenals, less blood to things like the kidneys, because in utero the placenta's performing the job of the kidneys and they're less important. And at this stage we start to see the head circumference decrease. Femurs are really variable. Femurs seem to kick in with their restriction and growth anywhere along that process. Finally then you get your metabolic deterioration, you get anaerobic metabolism, you're getting acidosis and decompensation. So the middle cerebral artery, that shows us that there's autoregulation happening and that the vessels are widening, so that in diastole now you're getting more flow through the arteries. And we know that this is associated with acidemia and adverse outcomes irrespective of the umbilical artery values. And certainly in late pregnancy after 32 weeks, it's a better predictor than umbilical artery values. Under 32 weeks, it's actually less. We certainly don't use it for delivery decisions, but it can be helpful, and I'll show you in a minute how, in guiding the frequency of monitoring. The cerebral-placental ratio, as we've seen, you get your umbilical artery PI increasing, your middle cerebral artery PI decreasing. If you divide the MCA by the umbilical artery PI, you get the cerebral-placental ratio, which is more sensitive than individual components and possibly a little bit more specific as well. And that has been shown to be actually the best predictor of adverse outcome. Ductus venosus, here we have, the umbilical vein coming in, taking blood from the cord to the baby. It's a little shortcut up to the right atrium, taking that really oxygenated blood to the right atrium. When the baby becomes acidotic, that affects the contractility of the heart, and so we see these changes in the ductus venosus where that A wave, which is the blood going into the atrium during atrial systole, that becomes lower and lower and lower and eventually absent. So that's a real end stage thing because that baby's acidotic and its heart isn't pumping well. So it is it's a surrogate for acid-base status. And we know that certainly once the A wave is absent or reversed, that the mortality is going to, that baby is maybe just a day or two away from death. As you're getting sort of 28 to 30 weeks, we don't wait for reversal, even just an consistently elevated venous pulsatility index is enough to prompt delivery. So we see these stepwise changes, and I'll go into these in a bit more detail in the next few slides, but from this slide, what you need to see is that the earlier you see clinical growth restriction, the faster that stepwise change occurs. So that very early growth restriction, you do get quite rapid change, whereas in the late growth restriction, it's really very, very slow. So this is what happens in early growth restriction. Initially, the uterine arteries may be abnormal, the cerebral-placental ratio first, and then you see changes in your umbilical artery and MCA. Obviously this is a generalisation, but you sort of do get this sort of stepwise thing happening over weeks. By the time you get absent end-diastolic flow in the umbilical artery, you've actually still got 7 to 10 days of progression before you actually have the absent ductus venosus, and CTG changes that we obstetricians love, they kick in really late. But these babies with early growth restriction, they're used to hypoxia and they tolerate it really well. And this progression is pretty steady, and we know that we can watch them, almost always, not always, but if they're very, very early, 25, 26 weeks, we know that we can keep on watching them even when we've got reversal of end-diastolic flow and wait for that ductus to change and stretch it out as long as possible. And that's been shown in big randomised controlled trials to have the best outcomes if we wait and push it that far with the early babies. In contrast with the later growth restriction, you've got your uterine artery becoming abnormal early, the cerebral-placental ratio changes, and then the middle cerebral artery. And note that the umbilical artery is not there. Often in later growth restriction, you just don't get an abnormality of the umbilical artery, maybe just enough to change the cerebral-placental ratio. But the important thing here is that acute deterioration, sorry, it's just a bit, thanks.
Mouse pad, yes.
Acute deterioration can happen suddenly, just over hours, and we don't get CTG changes until those final hours before that baby dies. And these babies, they don't have that tolerance to hypoxia that the babies with early growth restriction do. And that's why the CPR is much more important, and that's why we can't wait for changes to become worse than that. So just in terms of some pragmatics for radiologists and sonographers, just going to sort of talk about some of these things. That landed in my inbox about 8 months ago. Yes, we are requesting more growth scans, partly because our patients are becoming more high risk, but mainly because there's more and more recognition of how useful these things are and how much they can change outcomes. So because I'm a little bit on the dark side and I have sympathy with radiologists, so I went about looking at various guidelines. That's pretty much what we use in Australia. It's that sort of thing that we're being told. And so we at the Royal are not just making this up. This is the sort of stuff that they're saying. BMI over 35, 3 to 4 weekly from 28 weeks, and low PAPA, 3 to 4 weekly. So these are the guidelines that are out there. But because I wanted to help, I looked at other guidelines. I looked at the UK guidelines, and the others are worse. We'll stick with these because there are guidelines out there that mandate an awful lot of scanning. And in fact, maybe universal screening is coming. In 2013, a meta-analysis showed that routine scans did not improve outcome. However, looking back, people were scanning but not really actually doing anything different management-wise. SGA versus FGR, I'll talk about in a minute, but basically small for gestation just means looking at the size, whereas if you're thinking about growth restriction, you're looking at other things that might point to an adverse outcome. And certainly they weren't using the MCA and cerebral placental ratio. So in The Lancet in 2015, a large study was published where they did universal scanning, once at 28 weeks and once at 36 weeks, in 4,500 women. And these same women were also having clinically indicated scans as per the usual protocols. So the universal scan results were not communicated to the clinicians. Of that group, there were 352 small infants. And you see here that for selective scanning, basically what we're doing now, they identified 20% of the small ones and 30% of the very small ones, whereas scanning universally, you doubled or tripled those detection rates. Obviously a higher false positive rate, but possibly it's more important to find these babies. They also showed that the most important pointer to adverse outcome was a decline in the abdominal circumference growth velocity, followed by abnormal umbilical artery Dopplers. So defining growth restriction, small for gestational age, which we have traditionally talked about because it's easy, is basically just an estimated fetal weight under the 10th centile, whereas what we're wanting to find are those fetuses who aren't growing as they should be because there's a problem and who are at risk of adverse outcomes, and they're not necessarily the same thing. So building on all the studies that have been done, looking at what is associated with adverse outcome, this consensus definition, which is terribly complicated, was published very recently. So they divided it into early and late. Abdominal circumference or estimated fetal weight less than the 3rd centile, or absent end-diastolic flow qualifies you immediately, or you can be less than the 10th centile with abnormal umbilical or uterine artery Dopplers to define growth restriction early. For late, once again, if you are less than the 3rd centile, you qualify automatically by size, or otherwise you're looking at a combination of smallish babies, declining growth trajectories, and abnormal Dopplers. That's the definition where there is definitely a link with adverse outcomes, but we also need to be looking at these red flags where maybe it's not growth restriction definitely yet, but you're pretty concerned that they might be on the way. So small abdominal circumference, the old asymmetry, the bigger head, the smaller tummy, crossing centile lines, or oligohydramnios. So in terms of frequency of monitoring, now I know you guys have no control over where the requests come, but what we're aiming for as clinicians is it will depend on the level of risk. So usually it's about monthly for higher risk patients. It might be as often as fortnightly, or it might be just once or twice, depending on our level of concern. If those red flags are there that I mentioned previously, we probably want to be scanning fortnightly. And once we have confirmed growth restriction with a very small baby or abnormal Dopplers, we should be scanning twice weekly. And I really think that should be done by people who are experienced in high-risk obstetrics, and so women's imaging or the fetal maternal unit at the Royal, ideally, but some will obviously come out to other places as well from time to time. So a quick word on charts. I think somebody way back when put a lot of hard work in, and pretty much everyone in Hobart uses Hadlock charts, and that's great that they're standardised. I think at some point we need to maybe all get together and move elsewhere. Intergrowth was a huge multinational effort to produce standardised charts where they only recruited healthy, well-nourished women. And they did that in various centres all over the world. And what they showed was that irrespective of your ethnicity, if you were healthy and well-nourished, then fetal growth was pretty much the same. And so where we've in the past said, African babies are smaller or Asian babies are smaller, it's actually because socioeconomically there are higher levels of risk for growth restriction in those communities. So ideally, we should be using these charts. They look like that, and they can be obtained from the internet. Unfortunately, they're not yet available as a software package for ultrasound machines. They're still working on estimated fetal weight standards. And so we've been wondering, should we wait to change over until intergrowth does become available for installation on ultrasound machines? Or should we think about maybe changing to Chitty, which of the existing charts are the ones that correlate best with intergrowth? And that's probably a discussion that we have to have over the next 12 months or so. There is also an Australian estimated fetal weight standard, and I will use that to plot growth in babies where I'm doing serial scans. But once again, I'm not aware that it's available to install in the software packages for machines yet. So a word about Dopplers. Very important to standardise technique and make sure that we're using the same charts. This document, which you can get off the internet, is absolutely brilliant, and all of the sonographers that are measuring Dopplers should be familiar with it. It's not long, it's just beautifully set out, nicely illustrated. It's the bee's knees, really. But I guess just what drives me mad is when a sonographer measures a Doppler, doesn't think about it in context of the scan, whether it's normal or abnormal, or whether the baby's small or big, or whether it's a decent wave sign. They measure it, they report the number, the radiologist says, that's the Doppler, that's what it is, report the number, the obstetrician reads it, that's the Doppler, that's what it is, and acts on it. Sometimes that works. Baby that's well grown, nice waveform, normal value, that's great. But if you actually sit there and do the Dopplers again and again, you will realise they can be incredibly variable, and particularly if the baby's moving or breathing. So the recommendations are that they should be taken during fetal quiescence. That can actually be quite hard to achieve. So I tend to start with the Dopplers, because then if the last thing you want is to leave it to the end of the scan and the baby's bouncing around and you're 5 minutes behind already, and what do you do? So I tend to start with them, so if the baby's bouncing around then I have time to go back to them over the course of the scan. The other thing that has given me a bit of grief over the years is that the guidelines say we should report the value closest to expected. Now, if I'm scanning a 32-weeker that's really scrawny and I get 1 or 2 values that are normal and 1 or 2 that are abnormal, am I expecting I mean, what am I expecting? Am I expecting what's normal for a really scrawny growth-restricted baby, or am I expecting what's normal for 32 weeks? So I think if you're getting a lot of good waveforms and they're quite variable and you're happy that the baby's not bouncing around too much, it's actually quite reasonable to report the range. Because I think if a baby's growth-restricted, they're probably likely to flick into abnormal values more than a healthy baby. And obviously there are still, as careful as you can be, there'll still be false positives, and if a Doppler is going to influence a delivery decision, we really should repeat it. So in terms of which Dopplers when, I think we should always do an umbilical artery Doppler with any scan that's requested for growth. If we're concerned about the growth, or if the umbilical artery Doppler is abnormal, we should do the MCA, and all studies over 34 weeks we should do an MCA. Ductus venosus has fairly limited application to severe growth restriction probably under 32 weeks. Uterine artery Dopplers, once again, in terms of growth scans, probably it's worth doing them maybe just once, the first time that you're suspicious of growth restriction, just to see what they are, because it's interesting and they are associated with adverse outcome. But if you're doing all the others, they probably don't add very much. So why am I saying we should always do the MCA over 34 weeks? Because of this sort of study here. Now, just to explain this graph, what these people did was they calculated the normal range of cerebral placental ratio for babies that were 90th centile and above, and then they compared cerebral placental ratio to that. Now, babies that were below the 10th centile, as you might expect, had very high proportions of abnormal cerebral placental ratios, but even those that were still, above the 10th centile, but as they got smaller, they were more and more likely to have an abnormal cerebral placental ratio compared to those largest babies. And then if you dig into their outcomes, you find that a low CPR is actually more strongly associated with fetal compromise than is fetal size. And by that we mean operative delivery for an abnormal CTG or meconium. We mean venous and arterial pH at birth and the need for NICU admission. And it's also more strongly associated with neurobehavioural problems at 18 months than is fetal size. So I have now a small collection of cases where the MCA or the CPR was abnormal, the baby was otherwise well grown, and we said, oh gosh, it must be a false positive, and the outcomes have been poor. So we're going to stop doing that. We know there can be false positives, but we're going to take notice, even if the baby's a normal size. So just wrapping up now, this is for the radiologists, because there's a wide range of styles of reporting growth scans. And I don't really want to tell you how to do your job, but the things that we find really useful are to please, please, please give the values in centiles. Because as you've seen, all of the studies, all of our management is guided by centiles. If you say, oh, the baby's 34 weeks, but the abdominal circumference is about a 32-week size, it's almost meaningless. And it's just hard to interpret. Amniotic fluid, it's been shown that maximum vertical pocket, just the one measurement of the maximum vertical pocket, is actually superior to AFI for guiding management. I actually just report both because some of the obstetricians are never going to be weaned off AFI. Biophysical profile has not been shown to be helpful. And look, it's fine to say, and it's actually probably quite helpful to say, we saw good fetal movement, or we saw barely any fetal movement, or we saw fetal breathing, but to do a formal biophysical profile where you sit there and watch for this and that for 20 minutes, it just hasn't been shown to be helpful. And even if the clinician requests it, I have to say I tend to ignore them. And so this is a copy of a Viewpoint report. This is what we use at the Royal, and Viewpoint is a reporting platform for obstetric scans designed by obstetricians, and so this is how we like it. Oops. Indication first up. we really, really like to see the actual estimated due date and gestational age right at the top. It's fine if it's a private patient, but if it's a public patient who I don't know and the scan's been put in front of me, I really want to know that information first, and it's annoying to have to search through the body of the report to get there. The rest of the stuff, that can go anywhere, I don't really mind. And you'll see that in this one, because it's a follow-up scan, I haven't done the anatomy all over again. You don't need to do it every time. But then we've got the centiles there nicely for the biometry and for the dopplers and the MCA and CPR there. So that's a really helpful way to report. And yeah, I hope you don't all feel like that.